I'm Dr. Brian Parent, and Dr. John Mason and I make up Brazos Bariatrics. We're here to talk about obesity surgery. There's lots of different people involved in our practice who are interested in you losing weight and doing very well. Dr. Mason and I certainly, the surgeons are important, but there's also many other important people who are involved in our group as well. Our bariatric coordinator is Becky or Courtney, depending on the hospital. Our dietitian is Kay Fitz. Our support group leader is Lois Hansen. So there's lots of different people who are involved in wanting you to do well. And the studies actually show that when we do weight loss surgery as a group practice, not just us the surgeons, patients do much better. So what is obesity? This is what we'll talk about tonight. A little background on obesity and what effects that has on your health. What are our surgical options and how do those affect your health? And then what would your next step be? So obesity is a disease, and it always wasn't thought of as a disease. Only within the last 10 to 20 years has it been thought of as something that truly affects your health in a bad way. It's not just a cosmetic thing. So obesity is a disease of excess fat storage, and it's associated with a number of diseases, what we call comorbidities. A few things about obesity: it's multifactorial. It's not just that you eat too much or you don't exercise enough. It's typically lifelong as soon as someone becomes overweight. It's progressive, meaning that it can get worse as you get older. It's certainly life-threatening. People that are morbidly or too overweight die younger than people that aren't. And it's costly. It's costly from your price of everyday living, and it's costly from paying for health care as well. So how do we define obesity? We don't do weight loss surgery on just every patient. Most of our patients are about 100 pounds overweight. Morbid obesity is defined as a body mass index of 40 or more. You're severely overweight if your body mass index is 35 or more. So what is your body mass index? That's something that we can determine very easily. Your body mass index is basically your weight for your height. Because we know that if you're 300 pounds but you're 7 foot tall, that's one thing. But if you're 5 foot tall and you're 300 pounds, you're certainly much more overweight. So we have ranges of BMIs that we can put people into and determine how overweight they are. So a normal body mass index is 20 to 25. But it turns out that the majority of the population has a body mass index above 25. So you're considered overweight if your body mass index is 25 to 30. You're obese if your body mass index is 30 to 35. We start to consider weight loss surgery at a body mass index of 35 or more. And so you're severely obese at a BMI of 35 to 40 and morbidly obese with a body mass index of 40 or more. So you're not alone. The majority of the population is overweight or obese. A third of our children are overweight, and 75% of those children will be obese adults. 5% of the population in the United States is morbidly obese with a body mass index above 40, so 5% of our population qualifies for these weight loss surgeries. The medical cost for obesity in the year 2003 was $75 billion, and there were 325,000 deaths a year annually back in 2003 as well. So these numbers are probably double now, especially the cost. There's certainly probably $150 billion worth of healthcare expenses a year from obesity and obesity-related illnesses. When you think about the more common cancers that kill people in the United States, whether it be lung cancer, breast cancer, colon cancer, it's about 400,000 deaths a year. Obesity kills about 325,000 people a year, and so it's very close. You don't think of obesity as such a killer, but in fact it is. So if we look at a map of the United States that's color-coded for the percent of the population that's obese, you can see that what was in the past abnormal is now the new normal. Look at Texas. We have 25 to 30% of our population is obese or more. We've got some states in the South there that the population that's obese is greater than 30%. So this is a big problem. If we looked at this same map 10 years ago, there wouldn't have been that red. It would have been a lot of white and a lot of light blue. So a smaller percent of the population obese, and some states not even collecting the data. So this is a healthcare problem in the United States, and it's just getting worse. When we talk about obesity, again, why? Why are people overweight? Certainly behavior has something to do with it. What we eat, how often we eat, how much we eat. The people that we hang around with, whether it be family or friends, what kind of eating habits they have will influence us. Genetics have a lot to do with it. We certainly see patients in the office that their whole family is overweight. We see patients in the office that the whole family is skinny. So your genes that you inherit from your parents have a lot to do with it. And there are environmental reasons that the population has gotten heavier. We have escalators. We drive everywhere. We don't do a lot of walking. We spend a lot of time in front of TV and computers. We have remote controls. We can shop online. Our stuff comes right to the house. And so we as a population are more sedentary than they were in the past. Lots of different diseases are associated with being overweight. And if you look at the list, it's the more common health problems that affect the adults in the United States. But some of them, as the obesity has gotten worse, the percent of the population that has these medical problems has gotten worse too. Type 2 diabetes is a killer, and type 2 diabetes is an epidemic in the United States right now. And it's directly associated with obesity and being overweight. Diabetes affects your heart in a bad way, affects your nerves and your vision and your kidneys in a bad way. And so the healthcare cost associated with obesity and diabetes over the next 30 years is going to be quite high in the United States, and it's a problem that we need to fix. High blood pressure is associated with being overweight, high cholesterol. Respiratory diseases are made worse by being overweight, including asthma and chronic lung disease. A lot of our patients have sleep apnea. That's as simple as you snore too much at night, and you're loud and it bothers your spouse. We have patients that actually obstruct in the middle of the night and stop breathing for short periods of time. And that's true sleep apnea. They're walking around tired all the time because they're not getting that good deep sleep at night. Women have more problems with menstrual irregularity, even infertility if they're overweight. Women tend to have more problems with stress urinary incontinence. Certain cancers are associated with being overweight, like uterine cancer, breast cancer, prostate cancer. We see reflux in most of our weight loss surgery patients. Degenerative joint disease is something that's in most patients that are overweight. Most patients that come and see us have some sort of joint pain. Our joints are not designed to handle the extra weight. We all get wear and tear on our joints as we get older, but that's compounded exponentially if you're overweight. We have a lot of patients that need their knees done, their shoulder done, their back surgery, but they're just not a good candidate because there's too much weight on that repair, and the surgeons just don't want to do it. Gallstones and liver disease are associated with being overweight. You're more likely to have a heart attack and a stroke if you're overweight. And again, women can have problems with infertility as well. So a lot about the background of obesity, what it is, how we measure it, what effects that has on your health. But what are your surgical options? Are you a candidate for weight loss surgery? Typically, it's for a body mass index of 35 or more. You have to be healthy enough to undergo a major abdominal operation. Most of these surgeries are done with small incisions and less pain than in the past and a quicker recovery. But they still are major operations, and you have to be put completely to sleep for these. Some of our patients have to see the heart doctor to have a stress test. Some of our patients have to see the lung doctors to have their lung cleared. But we have very few patients that we have to turn away from surgery. All of our patients have failed attempts at previous weight loss. We have to make sure that our patients don't have drug or alcohol problems. You can't have any uncontrolled psychologic conditions. Now, we frequently see patients with depression or bipolar disease, but we just want to make sure it's controlled and get with your primary care doctor about that. You have to undergo a consensus by our multidisciplinary team. You see our dietitian, you see our support group leader, you see our educator, and you see us, the surgeon, and we all kind of decide whether we think you're a good candidate for surgery. You have to understand the surgery and the risk. A big part of why you're watching this goes along with a little background on the procedures and potential risk associated with that. But that's another reason we have everybody see a psychologist. We'd like to say that we can talk anybody into anything, anytime as surgeons. And the reality is that in the past that was happening. There were certain places that patients were having surgery and they didn't understand the risk because their surgeons just weren't telling them. And so the psychological evaluation that all of our patients do protects you from us. You sit down with someone who's independent of us, who will make sure that we've told you what we need to tell you, to make sure you've thought about the potential risk, the potential lifestyle change, and to make sure that you're a good candidate for surgery. You have to be dedicated to a lifestyle change and a lifetime of follow-ups, because it doesn't just stop at surgery. It's the diet that you follow post-operatively. Some of the complications of surgery can be worsened by patient behavior. So our job is to give you all the information you need to do the very best, and that's what we take pride in. Now, what are the risks of abdominal surgery? There are some risks that are associated with any surgery on the abdomen, whether we're taking your appendix out or removing your gallbladder or fixing a hernia. Things like bleeding, things like pain. Shoulder pain is when we blow your belly up with gas to do these procedures laparoscopic. There are rare risks associated with just being put to sleep in the medicines that they use. Deep vein thrombosis, blood clots in your legs, blood clots in your lungs, injury to intra-abdominal structures while we're working, infection. Most of the time infection involves a leakage along hookups that we do during these surgeries. Even death, there's a small risk of death associated with procedures. There was a recent surgery from a big program in the Northeast, however, that showed that the likelihood of dying from weight loss surgery is about equal to the likelihood of dying from gallbladder surgery. And so 10, 20 years ago, back when I was in training, the risk of dying from a gastric bypass was 1 in 200. Now it's 1 in 2,000. So it's because of programs, doing things as a program. It's because of accreditation. It's because the healthcare establishment is watching us and watching our results that they've gotten so much better. Risk of bariatric surgery specifically, hernia, chest pain. You can be dehydrated in the first few weeks after surgery because you're not able to eat and drink as much. Patients that lose a substantial amount of weight are potentially at risk for developing gallstones, and that's something that we can safely address down the road after surgery. Our patients are going to swell. We're operating on their stomach and their esophagus. You're going to swell within the first few weeks, and so mostly your diet is restricted to liquids. Some of our patients have vomiting and nausea as well in the first few weeks after surgery. When I was in training, they were just converting from doing most of these procedures with big incisions to laparoscopy. So now we can do laparoscopic small incisions to where the pain is not so much. You're up and walking in the hall on the night of surgery. You go home and you're able to take care of yourself that first post-op day. You're off of work for 1 or 2 weeks instead of 6 to 8 weeks. You don't have large incisions that can get infected. You don't have large incisions that can develop hernias. You're up on your feet faster. You're less likely to get blood clots in your lungs and blood clots in your legs. And so by getting you back to do what you normally do very quickly, our results have improved considerably. The gastric band is the first procedure that we'll talk about. It's done laparoscopic. Used to be the most commonly performed procedure for weight loss surgery. It's done less often now. So the gastric band, on average, patients lose about 35 to 50% of that extra body weight at a year. This is a little less than the other two procedures. It is an implanted medical device. It has the lowest rate of life-threatening complications afterwards. So what are the risks specific to the gastric band? This band is wrapped around your stomach. It's wrapped around the upper part of your stomach, and to function properly, it has to stay in that location. There are some things we do during surgery to keep it in that location, but unfortunately about 6% of the time, it'll migrate down on your stomach. We call that a slip. And when you have a slip band, it doesn't work very well and it causes severe reflux. We have to go back and fix that surgically. If the band is too tight around your stomach for too long, it can actually erode into your stomach. And that would be more of a life-threatening complication, but luckily that rarely happens. Most of the erosions we see are lap bands that were placed in Mexico. And it's not that they were placed in a wrong way, it's just that the patients had no follow-up. They didn't know why they were hurting, but they thought it was normal, and they showed up with an eroded band. If your band erodes, the band has to be removed and the stomach repaired. There's also lots of nuisance-related complications to a foreign body. The balloon that's around your stomach can pop and leak and not hold saline. The tubing can kink or pop and leak and not hold saline. The port we inject into in your upper abdomen can leak saline or flip over on its back and we can't stick it. So these are nuisance complications, and no one is happy when the foreign body itself fails, but we have to go back and fix that. So the diet with the lap band is very strict. It's more of a tool to help you lose your weight. The average weight loss that we expect to see with the lap band is about 35% of your extra body weight at a year. The most weight we ever expect a patient to lose with a lap band is about 50 to 60% of their extra body weight. The problem with the lap band is about 20% of patients never lose much weight at all. And there's a few reasons for that. One, it's very important that you come back and see us. You have to like your surgeon. You have to like the office staff. You have to be willing to see us back basically every month for the first year. Because we have to do the fills. We have to do the adjustments to make that band just right for you. Different amounts of restriction are different in everybody. And one size doesn't fit all. We've had patients that did very well for a few months. They had some restriction early on, had lost some weight, and then we didn't see them for 6 months. And we didn't see them because they got busy with work or with family. But their weight is going to suffer because of that. So you have to be willing to come back and see us frequently. I mentioned that the diet is very strict. There's nothing about the lap band that really keeps you from eating some things like ice cream and sugar drinks and shakes. And so the band just works by restriction. You get that hold up, and it kind of makes you feel full, maybe even makes you feel a little sickly. But potato chips and pretzels and ice cream are always going to go right through the lap band. And if patients are eating some of these kind of snack foods, they're not going to lose much weight at all. So you have to follow a diet. You have to follow it closely. We give you the diet. We don't want there to be any question about what you should be eating. But sometimes the lap band doesn't keep you from eating some of these snack things that you probably shouldn't be eating. And that affects the weight loss in a bad way. Recovery takes time and patience. This isn't something that you're going to lose weight, all your weight, in 3 months. Most lap band patients, it takes about 2 years for them to lose the majority of their weight. And again, you have to be committed to the follow-up. The gastric sleeve is the most common procedure that we're doing now. The gastric sleeve actually came from gastric bypasses. So we got really good at doing gastric bypasses in the early 2000s, so good that some of the more academic centers wanted to start doing them in patients that were severely, severely overweight with body mass indexes of 70 and 80. And they would get into these bellies and there'd be so much fat that they couldn't reroute the intestines to do a gastric bypass. And so they had to either abort or they needed a bailout procedure. So some smart person decided, let's just turn the stomach into a long, narrow tube. We expect that the patients will lose some weight, and we'll bring them back in 3 to 6 months to finish it to a gastric bypass. Well, what you can see is exactly what they did now. The gastric sleeve, removing about 2/3 of the stomach. Your stomach looks more like a long, narrow tube instead of a big reservoir. It can't hold as much food. Now, what happened in these patients is they started to lose weight. In fact, they lost a lot of weight. They were losing as much weight as their cohorts who had had the gastric bypass. And the surgeon said, well, you've done very well, but let's go convert it to a gastric bypass so we can maximize your weight loss. And they said, no, I'm losing weight, I feel great. And I'm eating pretty normal, so I want to wait. And the surgeon said, that's fine, we'll continue to follow you because we're studying you. And they saw them back every 3 months or so. And they expected them to plateau, and they expected them to start gaining weight back. Well, 6 months became 9 months, became 1.5 years, 2 years, and a lot of these patients did just as well as the gastric bypass patients. The thought then was, well, they're going to gain the weight back sooner than the gastric bypasses. But the more we follow the gastric sleeve, the more we know that it works almost just as well as a gastric bypass. And these patients have kept the weight off as long as the gastric bypass patients have. So the gastric sleeve came from the gastric bypass, but it's a little bit less of the rerouting of the intestines inside your abdomen. There's no hookup of intestine to your stomach. We basically just reduce the capacity of your stomach to hold food. The weight we expect to lose in the first year after this procedure is 60 to 80% of your extra body weight. There's no implanted medical device that can fail. There's no slips or erosions like there are with the lap band. What are the risks associated with this procedure that we didn't have with the gastric band? Well, we have a staple line. We've removed a majority of your stomach. And we have a staple line that's holding your stomach tissues together within the first few weeks. And so the worst thing that happens after a gastric sleeve is that that staple line leaks, and that causes a severe intra-abdominal infection. Now, the risk of that is very low. It's about 2%. But if it happens, it can make you very sick. Now, our risk of leakage from these procedures is very low as well, and our risks are just as low as they are in the major academic centers, but you have to know that that's an added risk that the lap band doesn't have. Patients always wonder, am I a ticking time bomb for the rest of my life with this staple line? The reality is that after about 2 weeks, your body has sealed over that staple line with its own tissues. And at that point, that's just you. You're sealed up, you're not going to leak after that. It's just within that first 10 to 14 days that the leak can happen. Now, long term, do we expect any complications of the gastric sleeve? We haven't really seen any. So besides the early risk of leak, gastric sleeve patients do very well long term. When they first started doing them, they were making them too narrow. Patients were getting strictures and obstructions, but we haven't seen that in our practice. We learned from the guys that did them early on, and they made the mistakes and taught us how to do it the proper way. So the diet is less strict than the lap band. It just keeps you from eating. And it works in 2 ways. Certainly you can't eat as much. You feel full very quickly. But it's not like the lap band where you eat too much and it makes you want to throw up. You just have that sense of fullness and I want to stop. We also remove the portion of your stomach that makes your hunger hormone. And that's something that the other 2 procedures don't do. It takes away your mind's ability to think and desire for food. Now, our patients don't become anorexic. You still want to eat, and it's behavioral. We sit down and we eat with our family and friends. You're just much happier eating with much less food, and you feel full. But there's not as much discomfort and sick feeling as there are with the gastric band and the gastric bypass. Again, the weight loss average is about 60 to 80% at 1 year, not 2. We don't see failures with the gastric sleeve. It just forces you to eat less. So the gastric bypass is the third procedure that we'll talk about tonight. The gastric bypass is a combination approach. The band and the gastric sleeve work by restriction. You don't eat as much. The gastric bypass works by restriction. You don't eat as much, but it also works by malabsorption. We actually make it to where you don't absorb things as well. Now, this used to be, like the lap band, during a certain period of time, the most common bariatric or weight loss procedure performed. And in the past, with big incisions in the 80s and 90s, this was really the only weight loss surgery that we had. And so it's been done for 30 years just with bigger incisions. The average weight loss that we expect to see with the gastric bypass is 70 to 80% at a year. Again, there's no implanted medical device like the lap band. And again, like I mentioned before, the risk of complications, the risk of dying from this procedure has really gone down significantly in the last 5 years. So what are the potential risks and complications of a Roux-en-Y gastric bypass? Again, you have staple lines, not just staple lines, but we actually hook your intestine to your stomach. And that new hookup can leak as well. And if that leaks, you can get very sick after surgery. You can develop ulcers along these staple lines where your intestine is hooked to your stomach. And so we have to keep patients on acid medicine indefinitely after this surgery. You have to take vitamin supplementation every day for the rest of your life. We've changed your capacity to absorb protein, carbohydrates, but also your vitamins. And so your vitamin B1 and B12, your iron level, you're not going to absorb those as well ever again. Even after you've lost all your weight, even if you have excellent results and you look normal and you feel normal, you still aren't going to absorb your vitamins as well. So it's very important for us to follow you closely for this in the first year. We don't see problems with the vitamins levels being too low because we follow it very closely. But again, if we lose a patient to follow-up and they're not doing the right things, they could get into a lot of trouble. We've had a few patients, younger patients, that lost a lot of weight. They felt good. They moved. They had new friends, didn't know that they had surgery. They felt normal, they looked normal, they stopped taking their vitamins. You stop taking those vitamin levels and that vitamin B level gets low enough, you can have a seizure, you can have permanent neurologic damage. And so, unlikely that that happens, all you have to do is take your multivitamin every day, but it's very important that you do so. We're never going to be able to see that distal part of your stomach ever again, or that first part of your intestine. So we usually do an endoscopy or an upper scope before surgery to make sure you don't have an ulcer or a polyp or anything in that distal stomach. We also see dumping syndrome after the gastric bypass. Dumping syndrome is where you have a small stomach pouch that doesn't hold much. It holds even less than the gastric sleeve does. If you eat something with a lot of carbohydrates or sugar in it, it overstimulates the nerves in the wall of your stomach. It sends signals up to your brain that tells you to panic because you're about to die. You start to sweat, you have diarrhea, and then you say, I'll never do that again. So that's dumping syndrome. Dumping syndrome keeps gastric bypass patients away from sugar. And most of our gastric bypass patients have experienced dumping, and it keeps them from eating the sugar. We've had a few who didn't experience it and were disappointed because it's a big behavioral change. And one of the things that can sabotage weight loss would be a lot of sugar. And so the gastric bypass has that added benefit of the dumping syndrome. Again, vitamin and protein deficiencies are possible if you're not doing the right things. We take pride in our program. We take pride in our pre-op and post-op education. And so as long as you're doing the right things and involved in our program after surgery as well, we don't expect to see that. The diet is less strict than the lap band, just like the gastric sleeve. You're going to eat less because of what we've done on the inside of your stomach and your intestine. You're not going to absorb the things that you put in your mouth as well. And so the weight loss is more likely to occur. We rarely see failures of gastric bypass. Now tonight we've talked about the potential failure of weight loss with the lap band and the fact that the gastric sleeves and the gastric bypasses don't tend to fail. That's short-term failure. We would expect that you would lose your weight with the sleeve and the bypass. We don't see many people that don't. But long-term, patients do gain weight back after these procedures, and they do because over 5 to 10 years, they get back into unhealthy eating habits. And so what we generally tell people is we get you back to your baseline. Very difficult to lose weight, very difficult to diet and exercise and lose weight with a body mass index of 35 or 40. But it's fairly easy to maintain weight with a normal body mass index with diet and exercise. And so long-term, that's why we take such pride in our education and what you should be eating. And the things that we have eating after surgery are not hard to do. It's healthy stuff, and it's not bad to eat either. And that's going to make sure that long-term your results are just as good. So which surgery is right for me, or which surgery is right for you? Maybe your age has something to do with it. What kind of health risks do you have? Do you have bad heart problems or lung problems? How much weight do you want to lose? Is the idea of stapling scary for you? Maybe you would opt more for the lap band. If the idea of having to follow a strict diet and you're worried that you may cheat and eat too many carbs and have difficulty losing weight with the band, then you should undergo one of the stapling procedures. Your eating behaviors have a lot to do with it. Do you graze? Do you snack? That's not going to work very well with the lap band. Ultimately, we don't expect you to make the decision right away. You'll see us in the office. We'll talk about you, your background, your history, your medical history, what medical problems you have. And all of our patients are able to come up with the procedure that they would rather have. We don't talk patients into one or the other. There's certainly programs out there that offer only the lap band or only the gastric bypass, but we just give you the facts about all three and let you make the decision. So the lap band, low risk of life-threatening complications, no staple lines, no risk of leakage, but less total weight loss, potential for failure, and you have to follow a strict diet. The gastric sleeve, again, the diet is less strict. You just eat normal things, it just makes you eat less and you feel full fast. You have the early risk of the staple line leakage, but you're going to lose more weight with than the lap band. And the weight loss is less dependent on follow-up. We don't have to do the adjustment of the lap band. And so although the follow-up is very important and we like to see you back and see how you're doing, you're not necessarily going to sabotage your weight loss by not coming back. And then the gastric bypass, potentially the highest risk of complications, potential for maybe the most weight loss. Again, like the gastric sleeve, we have less weight loss failures. But lifelong vitamin supplementation and close follow-up is very important after the gastric bypass. And are you going to be able to come back and see us? Well, what happens after surgery and after you lose all the weight? We take pride in not just patients feeling better and looking better, but we take pride in that we make you much healthier as well. I can remember being a medical student and working with a family practice doctor who had a very overweight diabetic person. And it was adult-type diabetes that the patient had developed as they got bigger and older. And he said, you know, if this patient would lose 40 to 50 pounds, the diabetes would go away. And that's the reality of diabetes in the United States. He said, you know how many patients I have had that are overweight that have lost the weight and the diabetes went away? And he had been in practice for about 20 years. It turns out none of his patients had. And so we have the ability to make the diabetes go away, but the weight loss has to go with that. And so with weight loss surgery, we're able to make the diabetes go away. So studies have shown that after successful weight loss, with either or all three of these weight loss surgeries, you know, what happens to the diabetes? 77% of patients after successful weight loss surgery, the diabetes is in remission. We don't say we've cured you of the diabetes, because it turns out that some people have a switch, and if they get to a certain weight, the diabetes switches on. The good news is if they drop below that weight again, the diabetes will switch into remission. 88% of those patients, the diabetes was improved. High blood pressure is very common in our patient population. 62% of the time we had patients off of all their blood pressure medicines. Some patients just have what we call essential high blood pressure, and it's not weight dependent, and so 80% of the time that was improved. Sleep apnea goes away in most of our patients. Cholesterol, we never really say we cure because they constantly change what they consider normal. But in 72% of our patients, their cholesterol was much improved. So you've attended this seminar, and we've gone over the weight loss procedures that we offer. So what would be the next step? Well, we'd like you to make a consultation to come see us in the office. Again, we talk specifically about your health problems, answer any questions you have, go over the surgeries briefly again. We kind of figure out which one is just right for you. We'll set you up for a psychologic evaluation that all of our patients do. Again, we don't think that you're crazy, but we just think it's important to have that independent source to make sure that you've considered weight loss surgery and the lifestyle change that it's going to cause. All of our patients undergo a nutritional evaluation, and then there's this insurance side of things, and we work on the insurance issues in the office as well.